So at this time, I'll go ahead and call Kelly McCutchen, who should be familiar to most of you in this room. He, of course, was my predecessor here at the Georgia Public Policy Foundation and still a great friend of ours as he is doing wonderful things with his friend Ross Mason at HINRI now. And I will let Kelly introduce his fellow panelists. So please welcome Kelly.
Well, thank you, everyone. Hope everyone's having a great day. I love being at these forums because it allows us to sort of drop the partisan labels at the door and really talk together about solutions to Georgia's mutual problems. And I think we've got a great opportunity, and it reminds me of 8 years ago when we started talking about criminal justice reform and got Judge Teske. We started that conversation, and leaders like Judge Teske, Governor Deal, and many of you in this room passed legislation, took that leadership role. Today, Georgia is the national leader in criminal justice reform. Over 30 states have followed our lead, and now at the federal level, they're discussing criminal justice reform. That is exactly what our founders thought that the states, as those laboratories of democracy, were designed to do. And I think we have that same opportunity in healthcare. I'll go ahead and have our speakers come up and have a seat. We have a great opportunity in Georgia because we're already leaders in global health. Many people don't realize that. With the CDC, people have heard of that, but the Task Force for Global Health, CARE International, and a whole host of others that many people don't even know the wonderful work they're doing around the world. They're headquartered in Georgia. We have fantastic healthcare institutions. We have great leaders. We have the foundation for innovation. We're a leader in health IT, a leader in fintech, a leader in logistics, a leader in biomedical engineering, a leader in regenerative medicine, artificial intelligence. All of the components we need to leap forward as things are changing, as the other speakers have talked about. We now have that opportunity because many people don't realize in the Affordable Care Act, there was a section 1332, that many people didn't pay attention to when it was first passed because it wasn't really enacted until 2017 before states could request these waivers. It's called the State Innovation Waiver. And that allows us to essentially rewrite all and any federal programs in healthcare. We have to keep 4 guidelines that you have to maintain, but other than that, it's really a blank slate. It's not just Medicaid, but it's the exchanges, it's almost everything. So it's incredible. It's the widest waiver we've ever had the opportunity to pursue. You have to make sure you're covering at least the same amount of people, that the benefits are comparable to current law, that you have protections for low-income individuals for out-of-pocket payments, and we don't increase the federal deficit. That's it. And that allows us the opportunity to address all these problems that we heard about this morning. So that's what we're going to discuss. So on our panel, we have John Haupert on the left, who's the chairman of the Grady Health System, and is another wonderful asset here in our community in Atlanta, and a great example of a financial turnaround due to John's leadership and leadership of a lot of the community leaders in Atlanta, great model for a lot of other public hospitals in the country. He's going to talk about a plan that Grady proposed a couple of years ago that we think really didn't get enough discussion. I think it's a really innovative idea, and he's going to explain that for you today. We'll talk about how we might be able to work that into a waiver. And many of you know Dr. Tom Price. He had been a long-time leader in the Georgia Senate. He was a leader in the U.S. Congress, and he led the Department of Health and Human Services. And he's another one of those great assets that Georgia has because he lives here and has all that breadth of experience to bring to bear to help us move forward in this area. So we're going to go forward and let John start out. And again, remind you, we're going to be open for questions. Write your questions on the postcards, and our volunteers will bring them up to us, and we'll answer those questions. Thank you, John.
Thank you. Well, good morning. Secretary Price and I had to have a little chuckle over here on the side of the room when Naomi said we were going to solve all the health care coverage issues in Georgia in the next 45 minutes. It was a little over 6 years ago that the Secretary and I were on a very similar panel at the North Fulton Chamber of Commerce having this exact same conversation. So we haven't quite solved it yet, but we are making progress. At Grady, we really have been focused on how we can transform care delivery. When the Affordable Care Act first came out, and after the Supreme Court decision around making state obligation somewhat optional, we began to look at how we as a healthcare system could contribute to increased access, but not just by solving access. We are very much concerned and also very interested in how we as a delivery system can improve the quality of care while reducing the cost of care. The dilemma we faced and do face at Grady is that 30% of our patients have no funding whatsoever. And when patients don't have access to some type of coverage, they oftentimes, or most times, will resort to utilizing the most expensive resource, which is the emergency room, for everything from primary care to emergent situations. And so the economic issue we have with unfunded care and with the uninsured in Georgia and anywhere else is the high cost of care that comes with serving the uninsured and the unfunded population. And so we have been very much focused about how can we design a care delivery system around that population that, number one, provides care in the right setting, which means usually not in the ER, but in a less expensive, more appropriate primary care setting. And how do we then begin to look at what the cost of care has been for that population, and how can we do a much more effective job at providing that care and reduce the cost. We undertook a pilot project at Grady beginning 2 years ago in conjunction with the Kaiser Foundation, and it was to take our highest utilizers of emergency services, most of whom were truly uninsured, unfunded, and to develop a care system around those patients that helped them deal with both the socioeconomic and health issues they are facing. And so our health system has, for the most part, been built around episodes of care, or episodic engagement with a primary care physician. So for example, I wake up, I've got a horrible cold, I call my primary care doc, I go see the primary care doc, and we deal with that issue, story over. What we realize with the population we serve is we have to surround them with the resources to move them toward better health. And so that means not only is there a physician resource needed, but there is social work needed, there's mental health needed, there is care management and care navigation needed, because as you work with these patients to help them best understand how to properly access the system, you also can work with them around here's what it means and here's how we together can work with you to improve your overall health so that your dependence on the healthcare system is not as great as it's been in the past. And so we started with a group of 100 patients that were our highest utilizers of emergency services, up to and including patients who were actually utilizing the ER at Grady once a week, showing up once a week, 50 plus episodes of care through the ER. And by implementing this wraparound model of care, we were able to reduce that group's utilization of the ER by 50%. We were able to reduce their overall cost of care to the system, to Grady, by 50%. And then the wonderful thing is we increased their use of appropriate outpatient primary care services by 140%. So we were able to take that 100, educate them, and as we say, from a health perspective, get them tuned up, address both the social, emotional, and health side of the equation. Because as a side note, it's been well proven that when people are in poverty, health is only really 10% of the equation in maintaining your health. The rest are the socioeconomic factors that surround that. So all if we're doing is addressing that 10% factor, we're not going to make the progress we need. And so we've now expanded that model and will continue to do so. So what we had proposed and continue to advocate for is utilizing dollars that are available to match federal dollars under either the 1115 or 1332 waiver program, to bring additional dollars, federal dollars, 2-for-1 match into the market, and in our case, that would be Fulton and DeKalb counties. And us utilize those dollars to develop what we would, in a way, is a capitated model of care at first in a demonstration project where we would take 50,000 patients who are currently unfunded, develop a model of care such that we've seen in our own demonstration project, whereby we then we take on the responsibility to provide that care without putting dependence and or additional cost burdens on the state of Georgia. We would take on that risk to create that model to provide that care, but provide that care in such a way that we're not only improving health, dealing with the psychosocial issues, but as a byproduct, by taking that population that has historically accessed very high dollar care and getting them geared into appropriate use of the health system, we will reduce the cost of care for that population, improve overall health, improve quality of care. And so it's a model that we've very much advocated for. We also want to be able to assess, is this replicable across the state of Georgia as a solution, or is a hybrid of that model replicable across the state of Georgia? But what we're really, at the end of the day, incredibly passionate about is just providing access. Access is a good thing. It gives people, access they may not have had. But it doesn't guarantee that we're going to see an improvement in the cost structure, bend the cost curve, and or improve quality of care. Access for just access's case doesn't really accomplish that. And so our Chief Policy Officer, Matt Hicks, is in the crowd, and he has been one of the key authors and designers of what we're proposing. But we really think that what we're proposing and or hybrids of it could really position Georgia to show the rest of the country how you can do this right. And by really looking at how we improve health, how we bend the cost curve, how we then, through that, create access, we think we can make a tremendous difference.
Good morning. It is great to be with you this morning. I want to thank Kelly and Kyle for allowing me to join you all. I want to thank the Public Policy Foundation for the incredible work that you all have done for decades, literally. It's great to be with John again on a panel, and we could probably do this every year, right? So and just keep rolling out the same ideas and same solutions. I was struck by Jimmy and Terry's conversation and the length of time that we've been dealing with CON, and so it does feel a little bit like Groundhog Day, but that's all right. Thanks to all of you for coming out. This is an incredibly important issue in terms of health care. I think it's a very exciting time for health care, but when isn't it an exciting time for health care? We've got some real challenges to face and look forward to the conversation that we'll have. I've spent over 30 years literally either working with policymakers or being a policymaker trying to help solve the challenges in the area of healthcare, and oftentimes get the question, all right, what would you do to fix the system? And some of you have probably mused about that, and I kind of chuckle every time I hear that question because, as you likely know, we don't have a healthcare system. We have healthcare systems, and you could, depending on how you count it, you could get up to double digits. But you've got Medicare for seniors, Medicaid for the folks at the lower end of the economic spectrum. You've got the exchange market. You've got the ERISA self-insured plans. You've got the VA. You've got the Indian Health Service. You've got the private market, individual and small group market, on and on and on. And all of those systems have their own rules and regulations, and that's one of the things that Jimmy and Terry alluded to is that how do you fix all of this when you've got disparate rules and regulations and requirements for the folks involved. And so what I thought I'd do is talk a little bit about the posture of the federal government, this being the federal opportunities at the state level, talk about the posture of the federal government, talk a little bit about the challenges that we've got, and then hopefully ignite some enthusiasm about Georgia and the opportunities that we have here. Much of healthcare, much of those systems are a federal-state partnership. So whether Medicare through the TPAs or certainly Medicaid is a federal-state partnership, as John mentioned, the SCHIP program, the exchange program, and so it's important to appreciate that how the states, what kind of flexibility the states are given allows for this innovation, allows for this laboratory of ideas out here across our land. Early in this administration, I was privileged to serve as the HHS secretary, and along with CMS, we put out a communication to the states that said, we want you to know, the states to know, that we're looking for new ideas. We're looking for creative solutions and incentivizing innovation in the area of healthcare. And HHS has certainly continued that. And so I want to focus on what that innovation means and how you do that. The logistics of that are the waiver process that both Kelly and John have alluded to. And there are all sorts of waivers that one can ask. It's how we address, as the chairman and Jimmy said, it's how we address this 13-plus generational period of time that the rules haven't changed that much, or they've been added on to, as we saw with the ACA. But how do you address personalizing or making it so that state rules are able to respond to the needs of the population? The way that you do that is through waivers. So I want to talk about three specific waivers. The first one is the 1115 waivers. 1115 waivers are Medicaid waivers. They've been around for a long time. There are 36 states that have either taken an opportunity to have a waiver approved or have a pending waiver that is in the mix. 10 states have not done anything as it relates to taking that option. Georgia is one of those states. But the expansive nature of what one could do as it relates to waivers in the Medicaid program, I just want you to think about and expansively challenge yourself to figure out how you can solve some of the challenges that exist in the Medicaid arena. So those 1115 waivers can deal with delivery system reform, and that's a soup to nuts kind of thing, and you ought to embrace that. Behavioral health. The challenges in behavioral health have continued to increase, and the waiver ability in behavioral health is real and should be, I think, utilized. Long-term care, we've seen much more need for long-term care, and the flexibility to respond to the user of long-term care is absolutely vital if we're to truly respond to those patients. Eligibility and enrollment requirements can be dealt with as it relates to Medicaid. The expansion itself, Medicaid expansion, has gotten a whole lot of attention because of what occurred with the ACA expanding it up to 138% of the federal poverty level. Some states have taken that opportunity, others have not, but I think it's important to think about how creatively you could address that population. Work requirements got a lot of headlines. We got 3 states that have a work requirement for Medicaid: Arkansas, Indiana, and New Hampshire. Kentucky's a special case that I'll touch on very, very briefly. And then benefits, the benefits for beneficiaries, co-pays, wellness programs, all those kinds of things. So if you think about that, that's a huge list of things that could be addressed through 1115 waivers. 1332 waivers, or the ACA waivers, or the state innovation waivers are again a very expansive, exciting way to be able to tailor the programs to the state population, and I would challenge you once again to also think about how you can make it so this is a Georgia-specific solution. The breadth of the ability to look at these waivers is similar to Medicaid. There are some guardrails, as Kyle mentioned. You got to make certain that it's as comprehensive and as affordable. You got to make certain that it it covers basically a comparable number of folks and it doesn't increase the federal deficit. But within those guidelines, you've got great latitude, whether it's on the individual or employer mandate, whether it's the essential health benefits package that folks have looked at, whether it's beneficiary cost sharing, the metal tiers that are out there, the bronze, silver, and gold coverage plans, the exchange and the marketplace requirements, and then the premium tax credits and CSRs, the cost sharing reductions. Only 8 states have taken a 1332 waiver. 7 of those have taken advantage of combining the resources from the federal government and the PTCs and the cost sharing reductions, and have a pass-through funding for that, and thereby be able to tailor their program for greater specificity to their population. Third waiver is 1115A waiver. It's not often talked about, but it again is huge breadth of opportunity. This is the CMMI program, the Center for Medicare and Medicaid Innovation, or the Innovation Center. And there's hardly anything in Medicare or Medicaid that you could think about that wouldn't be eligible potentially, along with the SCHIP program, that wouldn't be eligible for a potential waiver through the 1115 waiver program. Work requirements, I mentioned Kentucky. Kentucky had a work requirement that was approved by HHS. It was tossed out by the courts based upon Kentucky not following the APA, or the Administrative Procedures Act. HHS has reopened comments on that, and so I think that we as a nation will have some greater direction from HHS in terms of a rule prior to your next session. So I would urge you to think about that. The challenge that's out there is real. The uninsured population in the state of Georgia, 1.38 million is the last number, and that's 2015 data. Nearly 13% of the population still uninsured in this state. There's no cost shifting like there used to be in actuality, so that's a cost that's borne by the institutions and borne by the providers. In fact, I've said for a long time, the only thing that's truly holding our systems together is the altruism of the folks caring for the patients, and I promise you that gets old on their backs. The disparities are real. The disparities are real. As the chairman and Jimmy mentioned, there's a zip code that is just a few miles from right here that has higher mortality rates, higher incidence of disease throughout its entire population across all their age quartiles. You got increasing maternal and infant and fetal distress, and they are within blocks of some of the finest healthcare institutions that we have in this region and in this state, and truly in this nation. And so it's incumbent upon policymakers to ask the question, why? Why is that? And I would urge you, when you think about that question and you figure out what you think that why is, that answer is a potential opportunity for a waiver, whether it's in the 1115 area, the 1115A area, or the 1332 area. So I would challenge you to try to identify the problem that you want to fix, identify the solution, and then tailor a waiver request for that. Finally, I think Georgia can be a leader. I think Georgia can lead in a big way. We've got the size of the population and the size of the challenged population that allows us to do remarkable things. What John mentioned about Grady's proposal, taking 50,000 individuals and truly proving that you can improve their health status, as well as decreasing the cost to the state, but making it so that we focus on those folks that truly need the assistance. I think it's a politically opportune time to look at this. You've got a change of administrations coming in. You've got change of personnel. This is a great opportunity in terms of time to be able to fashion a waiver. And there are folks of goodwill who are truly interested in helping out. And I believe, as Kyle mentioned, that Georgia can lead the way, just as Georgia's led the way on criminal justice reform in the area of health care and addressing the needs of the vulnerable populations and populations that are currently accessing the system, but not doing so in a way that is truly allowing them to be responsive to the needs that they have from a health standpoint. So thank you very much.
Well, thank you, gentlemen. We get to questions. First, a few observations. I've heard from the healthcare experts that I deal with, they have a saying, if you've seen one community, you've seen one community. And they're all different. And that's why it's so important, not just for states to have the flexibility, but we really want to design a program where each part of Georgia has the flexibility to do what's right for it. You know, what's right for Grady and Atlanta is not going to be the same thing that Gainesville wants to do. It's not going to be the same thing that's right for Ludowici. So we need to have the flexibility there. The second thing that struck me as we were talking about this over the last year or so, during the height of the debate over the law in Congress last year that, you know, came a couple of votes short, there was a website that put out some comparisons between the tax credits in the Affordable Care Act and I think it was the BCRA, it was that bill. And they allowed you to click on counties, and they told you, you know, every county in Georgia, what's the average tax credits. I clicked on Fulton County, and the amount of money of the federal tax credit was more than sufficient to cover the cost of the program that Grady had proposed. So the money's there. But here's the problem. Both Republican and Democratic plans, there is an unfunded mandate. You know, you heard them talk about this federal law, it's called EMTALA, passed in 1986. It's sort of the fundamental problem, signed by Ronald Reagan. It says that our hospitals have to, you know, treat everyone regardless of their ability to pay. Now, as a free market person, that makes no sense. I mean, if that worked, then we can just solve homelessness and hunger by just saying all restaurants and hotels need to take anyone that comes in regardless of their ability to pay. Problem solved, right? But it creates lots of unintended consequences. Then you have the response in things like CON trying to address the problem when you're not really addressing the underlying problem. News is from a political perspective, we're not going to change the EMTALA law. We're not going to roll that back. And so you're left with an unfunded mandate, which I don't think anyone supports. We at the state level don't like it when the federal government does it to us. The local governments in Georgia don't like it when the state does it to them. So with the fundamental issue is this unfunded mandate. The Republican and Democratic plans both provide funding for these uninsured individuals, whether you call it Medicaid funding or whether you call it tax credits. The money's there, but the problem is, regardless of what you do, there are going to be people that aren't going to sign up. They're eligible, they can get that funding, but they just don't sign up for whatever reason, and that money stays in Washington. And then these people inevitably get sick, they show up at Grady, and they got to figure out a way to pay for them. We believe that through a waiver process, we can pull those funds down and automatically enroll them in a plan that can provide the reimbursement to address that unfunded mandate for our rural hospitals and our urban hospitals and all of our providers to address that fundamental problem, which then helps us create more of a free market for everyone else. That's the kind of opportunities that we're facing. So let me clarify a couple things, John. I heard you say that the plan that you had proposed did not include any new state funding. Is that correct?
Yes, that's correct. In this demonstration project with these 50,000 unfunded patients, we are proposing that the matching dollars be utilized to fund the program, and Grady and its providers are taking on the upside and downside risk of that program. There would possibly be some administrative costs that would end up in the state's lap, but we have even had several foundations who are interested in health reform even step up and say for a demonstration program such as this, and for what it could prove, we would be willing to fund that administrative cost. So truly no cost to the state.
And then on the tax credits that we were talking about, that under the conservative proposal, that was sufficient enough to cover the cost. And the other thing is that looking at the way the tax credits work, they vary by geographic area. So the tax credits in Fulton actually were some of the lowest in the state. If you go down into Albany and Tallahassee and South Georgia, they were about double. So there's a sufficient amount of money there. How can we use it? But that was a misconception, I think, about what happened when you proposed it the first time. It was going to be too expensive to the state. Well, actually, it wasn't going to cost the state any money. Getting back to the idea that you need unique plans for different parts of the state, in conjunction or at the same time, I know that Chatham County, Savannah, and surrounding areas were also working on a plan that was somewhat similar but had some distinct differences that reflected their community. And I don't know if that is still their plan, but could you tell us a little bit about how their concept worked?
Yeah, and I'll be the first to say I'm a lot less familiar with that, but in general, that was coming out of Memorial Health. Memorial has since been sold to HCA, so you're right, whether that proceeds or not is another question. But they were looking at a hub and spoke model, but also utilizing a waiver to use local funds to get federal matching dollars to help fund the coverage of the uninsured. So quite similar, but with more of a hub and spoke model. The model we have been looking at is also a hub and spoke model in a way, because we want to be able to bring in all of the primary care entities that serve the same patients that we do. So the FQHCs, Mercy Care. There's a number of those types of entities within Fulton and DeKalb that make up this two-county safety net infrastructure such that it is. And so we have to bring all of those parties into creating a system of care to help serve that population.
I wanted to mention that because I think, Jimmy said we need 40,000 people to support a hospital. That hub and spoke model is going to have to be the long-term solution. We want to have a hospital, and it might not, you might not have all the services, but you want to be able to stabilize people and provide primary care services, but then rely on some of our regional hospitals. I think that's really going to be the long-term solution, and the plan has to have the flexibility to allow that. Tom, could you talk about, I know, a year ago, the administration was encouraging states to submit waivers. Do you think that stance is still present? Are they still looking to actively work with states like Georgia to be flexible so that we can do something innovative here?
Yeah, it's actually one of the principal tenets of the administration, that is to try to encourage states to come up with their specific solution to their challenges, whether it be a statewide or in a region. And so I have had conversations with folks in the department, and their posture remains exactly the same. In fact, continuing to encourage states to come up with some innovative ideas and request waivers on both Medicaid program and on the exchange market. But if I'm sitting out here, I'm listening to John, and I'm saying, now wait a minute. This isn't gonna cost the state a thing. The proposal that Grady put forward isn't gonna cost the state a thing. You say, well, how are you gonna do that? And you have to tie what he said during his remarks with the proposal, and that is that they reduced in those 100 individuals costs of health care by 50%. And the feds are gonna match 2-to-1 the monies. So if Grady's gonna put up 50 million, for example, and the feds are going to and we're going to pull down 100 million from Washington, and you're going to save 75 million, then that's what you call a win-win-win. And we just need policymakers to recognize that there is an opportunity to have a win-win-win with folks who are truly interested in moving forward and solving the remarkable challenges that exist really not far from here.
If you all would please submit your questions now, we're ready to go to questions from the audience. So write a question on the card, and we'll bring them up. Let me ask Tom another question. The 1332 waiver program, these state innovation grants, there have been 7 or 8 states that have come forward. Frankly, they've been a little disappointing on the innovation side. Many of them have risk adjustment and other kinds of mechanisms, which are important, and which we could help Georgia as well. But what do you think the reticence is among states?
Well, there's a lot of, there are 8 states that have done it. Hawaii and Alaska are, along with a number of other states. And 7 of the 8, as I think I mentioned, have taken advantage of this pass-through funding. So pooling the resources from the PTCs, the premium tax credits, along with the cost-sharing reduction money, and then utilizing that in a way that hopefully is more responsive to their population. Hawaii simply had they had health plan in place already for their small businesses, and they didn't want to have to utilize the small business shop program, and so that was what they did with their waiver. But as I mentioned, the opportunity that exists out there for 1332 waivers, or these state innovation waivers, is broad and expansive. Whether it's the mandates, whether it's the metal tier levels, whether it's the eligibility requirements, or the essential health benefits, or the beneficiary cost sharings, or the kinds of things that again, you think about that individual and small group market, by and large, that was addressed through the exchanges and the challenges that they have. It's a soup to nuts opportunity to be able to fashion something that works for the state of Georgia. So I would again encourage folks to think creatively. There is a receptivity on the part of the department and the part of Washington right now that hadn't existed before, I believe, and I would urge you all to take advantage of it.
We've got a lot of questions, so we'll try to get through as many as possible. So you discussed changing the delivery of care model. Does this include looking at professional licensing reforms and categorizations like dental therapists, particularly as it results in rural Georgia? You know, there's a shortage of dentists, just like there's a shortage of doctors. Can we allow for people to perform at the highest level of their license, like several states have passed these dental therapy laws? Have you looked at anything like that, John?
So within Grady, we employ, and in conjunction with our academic partners with HINRI and Morehouse, we employ a significant number of advanced practitioners, but they are all working within what is currently provided within the state. We have not, in our current model, looked at any changes in the care delivery model that we're proposing that would then challenge what advanced practitioners are able to do under Georgia law.
Scope issues are really state issues, so the state has the opportunity and the authority to determine how folks are able to practice in the clinical setting. They tend not to be federal issues except through the VA.
This question is regarding Medicaid expansion. We heard about hospitals closing in Georgia. You all may or may not know the details of each individual. This might be a Jimmy question, but would those hospitals have closed if we had expanded Medicaid in Georgia?
Well, I think what Jimmy did say is that the hospitals that closed, it was a financial decision, so let me marry that issue with the one that you mentioned, that is the EMTALA law. The fundamental problem is that we've got, again, about 1.4 million folks in this state that remain uninsured, and the reimbursement for folks in other areas, especially Medicaid, oftentimes doesn't keep up with the cost of providing the care. So the solution is to get folks covered in whatever way one wants to do that, and that's up to policymakers. But I would urge folks, as I always tried to do, to make certain that our goal is to have everybody covered in some form or fashion, and then to make certain that the reimbursements on the Medicaid side are adequate to be able to cover the costs of the services. Would those hospitals not have closed if the expansion had occurred in this state? I don't know. You'd have to run the metrics on each of the hospitals. But I do know that a solution for so much of what ails us in the area of healthcare is to have a system or systems that provide for coverage for everybody in some form or fashion, and make it so that it's responsive to them, affordable for them, allows them the accessibility to the kind of care that they want for themselves and for their families.
I would add, too, that with Medicaid, one thing that John pointed out is a significant investment in primary care, and which is a challenge with Medicaid, because so many doctors do not accept Medicaid, and that's why they end up in your emergency room, because they can't find that care. The plans that we like to see would be like yours, those surrounding them with mental health services, strong primary care. Direct primary care is a concept we've talked about a lot. There are a lot of great clinics around the state that provide good services that we could support, but the funding's got to be there, and that's where we could use that additional funding, I believe. This is a good question. What can be done besides expensive high-risk pools for vulnerable as well as middle-class citizens to ensure individuals with expensive, debilitating diseases like MS, cystic fibrosis, and Parkinson's have high-quality coverage that covers procedures and cutting-edge drugs based on decisions by providers and patients?
Well, there's a simple question.
Yeah, whoa. That sounds like one you'll be able to answer.
The challenge of high cost folks who have disease states that cost a huge amount of money is one that is a real conundrum. But if we had a system that truly allowed for the flexibility of individuals to gain the kind of coverage that they want, not that somebody decides or forces them to purchase, then as Kyle has said multiple times, the money is there to be able to provide the services. We know that. There's a couple states, I think it's Nebraska and Maine, have instituted what they call invisible high-risk pools, which is to provide for folks who have and I think they take the top 8 or 10 diagnoses that are the most expensive. And once an individual receives that diagnosis, then it's not that they fall into something else. They are transferred to a high-risk pool, and there is a subsidization from the state that then allows for care coordination and greater resources to be brought to bear for those individuals, the ones that you describe in the question, that make it so that they can receive the kind of coverage and the care that they need, but they're outside of the other pool, if you will. Remember these systems, these siloed systems that we have, so that it doesn't drive up the costs for everybody else. And in fact, if you look at that population, depending on who you read, it's somewhere between 4 and 8% of the total population. And so if we were to truly focus on the sickest of the sick, which is a proposal that was put forward years ago, decades ago, and provide greater coordination of care for those individuals, we actually lower the cost for everybody else, which is why you can have the kind of resources that we have right now for the entire system work and provide the kind of care and coverage that's needed for everybody. But the flexibility isn't there to do it, hence the need for the waiver process that we've discussed.
If you want to keep a bunch of policy wonks busy for about 4 hours, ask the question, what's the best approach, high-risk pools versus risk adjustments versus reinsurance? And they'll just go off and debate. There are a lot of tools, and I think we've got to address this problem. I think, again, the pre-existing condition question has been settled among public opinion, but there are much more effective ways to get at it. We'd like to see the money follow the individual, so you actually create a market where people, as opposed to normally now, the insurance companies want healthy people and don't want sick people. If they actually carried a price tag that came along with them, the funding that represented their cost, we want to be the best facility in the state for treating diabetic patients or MS patients. And the market can work, but we've got to get the market incentives right. And what we're seeing now is, yes, you've got coverage, but we have these really narrow networks, which is the only thing that we can control cost, and the specialists that you really need are out of network. And so it really doesn't do you any good. So that's a critical question that we've got to address. This is a good one. We've all heard the bumper sticker that says, if I'm shot, take me to Grady. Should Grady get funding from all the other counties in the state that send people to Grady?
Oh, that is a good question, I'm actually glad that one got asked. There is a multi-decade belief that counties outside of Fulton and DeKalb, quote, take advantage of Grady and the services we provide, trauma, burn, stroke, where we are the answer. And we've looked at that issue very closely, and the truth is 89% of all of our patients at Grady come from Fulton and DeKalb. That other 11% come from outside of Fulton and DeKalb, but are really only specifically for those services not available elsewhere, and particularly, for the most part, burn and trauma care. And so those patients are flown in or via ambulance to us truly in a crisis state. A vast majority of those patients are insured, and so we're not putting a burden on the funding that we get from Fulton and DeKalb. The funding from Fulton to DeKalb is entirely intended and only utilized to provide care to their citizens who have no insurance. And so that funding doesn't end up serving people in other counties. The real clincher was when we figured out that there's actually more citizens from within Fulton and DeKalb who are unfunded, who are going outside of the two-county area to get care. And so you begin to hear from those county commissioners in those outlying counties surrounding Fulton and DeKalb, maybe we should send Fulton and DeKalb a bill if Grady, that whole saga. So the old misnomer about these outside counties are taking advantage really is not true.
Tom, you talked about behavioral health, or both of you did actually. And there's a federal law that requires insurers to provide equity for mental health benefits. There's very little financial relief for much needed treatment of mental disorders in Georgia, especially for long-term facilities. What can we do about that?
Yeah, some of this is federal constraints, the length of stay that individuals can have in a behavioral health facility. A lot of it is funding resources that haven't been brought to the table. Again, part of it is what I discussed before, that if you allow for the flexibility of the utilization of the resources in a way that is responsive to the individual users, then you could have the opportunity to spread some resources around and care for those with behavioral health challenges. The waivers that are available through the 1115 system, the Medicaid system, really haven't been taken advantage of to the degree that I think that they could be. And so if this is a passion of yours, and it certainly is of mine, then I would urge folks to again think creatively and expansively about the kinds of things that you think could be fixed or need to be fixed from a behavioral health standpoint, and then let's lead. Let's figure out the solution that we think best aids our population, and try a different way. Because certainly what we've done right now is a tragedy. Every one of you has a story about somebody who has had, or a family that's had, a behavioral health challenge, and if you talk to those folks who've tried to navigate through the systems that we have right now, it is a nightmare by and large, and it's we're not doing ourselves or our society a service in the way that we've handled behavioral health.
And that'll have an impact on the criminal justice system, our educational system. There's students out there that need services, so many different areas, veterans, all across the board. So I think certainly mental health is going to be very important.
If this is a passion, I would urge you to call your attention to a book. It's entitled Crazy, C-R-A-Z-Y, Crazy, by Peter Early, who was a journalist, I think, in Florida, and his son was diagnosed with schizophrenia in college. And just that describes the challenges that he and his son and their family had trying to navigate through the system, and it will bring to light and it will wake you up on just the difficulties, the hurdles that we have in our current system as it relates to mental health.
John, love your ideas about changing the care delivery model. The previous panel suggested maybe that rural hospitals perhaps might not have evolved to that level. What can we do to spread this model throughout the rest of the state?
Well, and Jimmy, I know, has spoken on that issue as well, and I know has some good thoughts around that. It really is important that what we learn from whatever it is we do at Grady, we make sure it is replicable. And I think one of the big sticking points will be what local funds are available to serve to match or to pull down the federal funds. But that can be replicated. But I would also state that there are many rural facilities across this state that have come up with very imaginative care delivery models. It's not all just the traditional model. Jimmy hit it right on the head. We have a lot of counties in the state. And we have a lot of communities with a hospital with far less than 40,000 population, and the economics just don't make sense. And so it's going to have to be much more of a how do we regionally redesign care so that a larger population is served by maybe a group of facilities doing different things. But the care delivery model and more intensive care management applies anywhere.
We have 1 minute left. Final thoughts?
Did we solve the problem?
Yeah, we solved the problem, right? Well, I would just challenge all of you. I think Georgia can be a leader. I really do. This state is as diverse as a state can be. This state has has as many challenges as anywhere in the area of healthcare, but it's got a wonderful leadership population. I think the time is ripe now from a political standpoint, and I do think that if you think creatively and innovatively and expansively about what kinds of things we can solve as a state, we can truly lead the nation.
And I would second that and just add, when you look at the economics of providing care to the uninsured and the model that we're currently doing so in Georgia, we are basically proponents of the most expensive care model there is. And why would we do that? Why would we not want to take advantage of these waiver programs and be able to design a care delivery model in Georgia that really can be, I believe, would be the model for the rest of the country?
Well, thank you, gentlemen. This has been a very interesting panel, and we hope this is the beginning of a conversation that I know the Georgia Public Policy Foundation, just like with criminal justice, we'd like to provide that forum for people that are passionate about this to get together and discuss it. It took us 8 years in Georgia. We can't do it all in 1 year, but hopefully this is the beginning. Please thank our panelists, and appreciate you coming.
Good to be with you.
Good to see you again.
Yeah, likewise.
All right, we are going to take a 5 to 10 minute break and rejoin at 11:15 to talk about pension reform. So please go take a break and we'll be right back.